Welcome again, Gunther. Welcome again, Stephen. I want to leave it up to you to have the most time. Just one thing, you all find at the bottom of your screen a possibility to choose a channel. In which language do you want to follow this? So Birgit Meyer will consequently translate everything from English into German, because Gunther and Stephen will speak in English. You can ask questions in the chat. Please do it in the chat. Sonja Heinrich and me from the Karl Auer Academy and the Polyvagal Academy will choose some questions. So at 10 to 6, we can have 2 or 3 questions. Please understand that is not more time to have more questions, but save your questions to the conference at the 22nd of June. Welcome, Gunther. Welcome, Stephen Porges. Gunther, it's up to you.
Oh, thank you. Hi, Stephen. It's a pleasure to meet you again after some much longer time than we wanted to have you again here in Germany, at least in this way, because of the COVID situation. Something has prolonged, okay. But now we have the chance finally. So it's a pleasure for me to talk with you.
Well, I've missed our interactions and it's been too long. I look forward to actually the future where we'll be face to face.
Yeah, I hope so. Yeah. Well, I just start already with the thing. At first, I want to thank you very much for developing all those wonderful theories and this research-based knowledge, which we have finally won by your so important work. For me personally, it was a very intensive relief when I first read about your work, because I'm coming from the systemic field and was one of the pioneer group in Germany who brought the systemic approach to the German language area. But after some years, I thought that is not enough. And I went to Milton Erickson and then developed this hypnosystemic approach, which integrates the knowledge of the working with the involuntary processes in the unconscious mind, and also with the systemic approach. The systemic approach in this tradition had a long tradition of more cognitive-oriented interventions, and from my understanding, that was not enough. When I then talked about Polyvagal-Theorie, a lot of systemic people also said, what do we need this? We have such a wonderful elaborated thing. What do we need? Things like that, like a Polyvagal-Theorie, because, but then in youth supervisions, people came in and always wondered why, for example, they worked with somebody who was very trembling, was in a panic attack, or had traumatic experiences, and they asked him, what can I do for you? And the people just didn't answer. And so they asked again and again, and there didn't come something. What would you have an explanation for when somebody is addressed in this way, but being in such a mood that it's not that he doesn't want, but there's something else going on?
That actually is one of the major questions of what is it to be a human? Let's really get down to that level.
Yeah.
And what that you're really asking the question is, when does my intentional behavior, my intentional mind lose control of my body? When does my body run the show? And I often sit back and ask people a simple question. Have you ever experienced a point in time in your life where even though your intentions were to do something, your body said, I have to do something else? And Polyvagal-Theorie explains it, because it explains this, I would say, biological motivation to survive as a foundational survival mechanism buried low in the brain, in the brainstem. And our intentional cognitive mind is quite a recent evolutionary innovation in the phylogenetic journey of vertebrates. And that phylogenetic journey, of course, was to have a larger and larger cortex, more mental activity, but it was also about this capacity to turn off threat reactions. And this is really the underlying basis of why therapy works, why relationships work, why society works, that we are not an individual organism that self-regulates. We are part of a connection with others. So our biological imperative is to connect. We can't connect unless we can turn off our basic survival reactions. And when those survival reactions are rekindled, and this is what we're describing, it's not the most fertile field for social interactions.
So in a sense, you could say when somebody is addressing or asking somebody, when he's in an unsafe, in a threatened mood, things which address at the cognitive level, it's just as if he would send a message to another receiver, but the receiver isn't there, so to speak.
Exactly. If we discuss the priorities of our receivers or our systems, they actually, the priorities is really goes down to very primitive foundational priorities, survival. If the body is in a state of survival, the intentional aspects, that higher cognitive function, doesn't have, the word would be valence, much power. It's subservient. And so when people get angry, they always understand that, or a baby's in the state of tantrum, or a dog is barking and chasing you. We understand that. But when it comes to our therapeutic models, we haven't really incorporated it. And in our own interactions with people that we care about, we're always in this dialectic bind where people talk in the most rational way about what they should do, what they shouldn't do. But when their physiological states change, they're at the mercy of their bodily state. So they're pontificating instructions to a person without witnessing that person's physiology state. So it all works if we, in a sense, become better witnesses of other people's physiological state. And the beauty, and this is an intellectual, the word beauty in terms of an intellectual concept of understanding our evolutionary journey, is the beauty that we as a social mammal have this toolkit to downregulate threat reactions. And that is the pillar of everything in our world, our social world, our world of commerce, our world of politics, our ability to turn off our innate survival mechanisms. How do we turn them off? And that is the challenge to therapists. How do you turn off the defenses in others? How do you convince the nervous systems of the client that you are safe to be in their proximity?
From my understanding, and this is from my work, and when I train a lot of people in Germany and the German language area, very important. That means that just when you want to support people and help people, the first step is to work with yourself, because if you work with yourself and you can develop a kind of a mood inside yourself, which then can represent a context of safety, of appreciation. And so then it enables, because what I like so much in your work also is that it's an interactional, it's a reciprocity concept very much, and that it's not only from the individual in itself possible so much, we are relationship beings, and therefore so, and that means also that if a therapist wants to support somebody, obviously, so I understand your work, that when somebody cannot talk or he behaves in a strange way, the first thing he had to do is, in a very, in a sense, caring, loving, understanding, empathetic way, to assume this comes from a level of being, of experience, which is very, in a sense, meaningful, but not for the cognitive context, maybe.
Yeah, so let's, in a sense, unpack what you said. You said a lot of things.
Yeah.
We're going to actually start with the word empathy and say, can we, in a sense, not use it? And we're going to not use it because of what we've learned from the trauma world. When a person is telling their narrative, their story of trauma, and they're telling it to someone else, and that person is empathic, that person is reacting and sharing the pain with the trauma survivor of trauma. survivors of trauma do not like to inflict pain on others. So in the act of telling their narrative, they are in a sense in a dyad now of experiencing what that narrative is doing to another. And that's why many of them won't talk about it. And so the real issue is, can we respect what empathy is, because we are human and humans have feelings and they share feelings, but can we move it up a notch? Can we move to a level of compassion in which we are really now a support and a witnessing? We respect the feelings, but we don't dive into those feelings.
Exactly, yeah.
And that's a hard task. So we want to go back to this initial question, which is, what do you do as a therapist? Because if you are a therapist, you're also a human. If you're a human, you're sensitive to the pain of others. So the first thing you need to do is be able to literally broadcast your physiological state as being a safe state. And what does that mean? It means that it's not necessarily the words you're saying, it's how you say the words, the intonation of your voice. And this reaches back to our evolutionary heritage as social mammals. Mammals convey their autonomic state in the intonation of their voice. The laryngeal and pharyngeal nerves that produce intonation are vagal nerves. So in primitive, I'd say earlier mammals did not have heart rate monitors to measure vagal tone, but they had voices. So they were projecting their physiological state to their species, conspecifics, those are their species. And that would send the signal of either a safety cue or a threat cue, where you're now understanding the physiological state of the other. And if they're sending safety cues, which would be intonations or vocalizations, which we call prosody, then people got physically closer together. Mammals got closer together. And this is really what we see with a mother and a baby. And it's really wired into us. How do we talk to babies? We use a prosodic voice. How do we talk to our pets? We use a prosodic voice. So we're creating the setting conditions of that interaction by broadcasting our physiological state. We also broadcast it in our facial expressivity, especially the upper part of the face. If the upper part of the face is working, our body knows the person's safe to come close to, or at least it thinks. I would say it thinks. It reflexively accepts the person. And so you have a smiling face or flexible face, upper part of the face. But if it's the lower part of the face and the upper part of the face is blank, we often get scared of the person because their jaw muscles of the mouth are muscles to bite and hurt. Watch a dog when it moves through its different states, from its eyes to its jaw, and we understand exactly what those systems are communicating. So let's go back to the real point of the conversation, as the first thing is not that we have to broadcast that we're in a safe state. The first challenge is, what state are we in?
Exactly.
So we have to, in a sense, develop a skill not merely to witness our clients, but to witness ourselves.
And then from that on, yeah.
Right.
And also, what I feel important is maybe that was that I had not this word compassion, but from my experience, the best way I can support somebody is as if I would be in two levels of experience. Yeah. In one, I'm just with the client, but on the other side, I'm outside. I'm on a meta position in a sense, from which I can also signal, hey, whatever you can offer, I'm here. Yeah. And like a stable supporting power or something, a two-level communication, so to speak.
To have that resource, your body cannot be in a state of threat or defense. So you're basically have to be resourced. And this is a word, again, clinicians use that. But what they're really saying is that their autonomic nervous system is exhibiting flexibility, that it has a range of experience, but all that entire range is contained or constrained by the sociality. In a sense, our social engagement system, our interrelationship, so we can get worked up, but we can calm down. And when we do that, activities become playful because they always end up in a safe, calm interaction.
Mm-hmm. That brings me to this question. What would you suggest, for example, therapists, but also to other people, to regulate these kind of processes? When you compare from the social engagement system as the highest level, so to speak, high, just it's in a metaphorical way,
Yeah.
and then fight, flight or something on the other, and then freeze and faint or so. When somebody's in a freeze state or in a fight state, mm-hmm. Would it be better to try to regulate top down, or starting with the process of the direction of it?
Well, let's talk about directionality. There's top down and bottom up, and in general, we're using both. But you're asking the question is when a person is in a, let's say, global defensive, whether they're using fight flights with the sympathetic nervous system, with muscle tone, where the body wants to fight off a person or run away, or is their body as crumbling, shutting down, immobilizing, trying to disappear. And in clinical areas, it often leads to dissociation. I'm going to say the beauty, the really instinctual intelligence of our nervous system is that if the social engagement system is available, it choreographs and regulates the rest of the autonomic nervous system. It says signals to it that you can mobilize, but you're not fighting or fleeing, you're playing, or you can immobilize. And with social cues, you immobilize and you have shared moments of intimacy. And this starts off with the young infant conforming to the mother's chest. And it continues in terms of the ability of peers to co-regulate each other. And it's part of all helping professions where we are sending cues to be helpful to others. Helping professions, not just in medicine or mental health, but in education and coaching. And allied health include. I did forget my colleagues in all these other areas, but because it's the same. They're creating a relationship. That relationship is literally enabling their social engagement systems to enable them to move into these other states. Mm-hmm. So, but there's some clues. I will say that this is part of what I am learning on this interesting journey. And the journey is being greatly informed by my interactions with clinicians in various disciplines. And that is, there is this amazing portal of movement. So when I started, I was very focused on you want the social engagement system and you want to be able to sit still literally through co-regulation. And I was not respecting the fact that this was too much of a challenge for many people. And what I've realized is that the movement dance therapy world had some very important hints that if you enable people to move and you enable social engagement to occur while moving, the body doesn't feel the same level of threat or surveillance that when you ask an individual sit still to do even something like mindfulness. Again, the mindfulness people learn so much when they try to apply it to survivors of severe trauma. The survivors just said, I can't sit still and do this. I have to get out. Mm-hmm. But if they had created a different mindful exercise to incorporate movement, they probably would have had the portal of entry would have been, would work better.
But that in a sense also means for me, when somebody is in such a survival mood, at the first step, it would be helpful also. We have a lot of good experiences in the Systelius clinic, which I have founded together with some other people, where we're always inpatient with 80-90% work. When, for example, somebody is in such a survival state, we just don't make a conversation in sitting. So, but at first in moving during the session, and later on we can go to the other places, as if in a sense talking is not enough, but but the others, the other channels can also be there, and so but that is also especially for therapists. I think they need an understanding that it's not only the talking cure, like it was, that was the name usually in Germany and in English for psychoanalytical work, for example. It's not a talking cure, it's an encountering cure on every level of experience. Could you say so?
Yeah, I would, in a sense, go back to the talking cure for a moment and realize that in articulating it as a talking term, cure, we emphasize the language. Mm-hmm. We didn't emphasize vocalizations. Mm-hmm. And if we had emphasized vocalizations and said whatever you say is irrelevant, it's not the insight, it's the neural exercise of vocalizations is a therapeutic tool, just like chanting and singing and breathing. It recruits this wonderful neural platform that enables flexibility to occur. So I think we got misdirected. And because we kept on thinking that we're this unique species that has complex language, and this language is high up in our brain, and it will control those primitive, more animal-like functions. And the answer is yes, a lot of the time it will. But when the cues are survival-oriented, it can't do that. The body will allow you to do that. And this is really what we learned from the survivors of trauma. We learned that their body said, no, I'm not listening, I'm doing something else.
That was exactly this kind of experience what brought me from from working with a systemic approach to developing the hypnosystemic approach, because in the hypnosystemic approach, all these different levels are even maybe start talking in the beginning, humming with each other, and then afterwards you can come to the other.
You said a lot there, because when you said not merely just humming, but humming with each other. Now, the humming in itself is breath, facial muscles. It's a social engagement system, and now it's dyadic. It's interactive. What you're describing is a powerful neural exercise that will shift physiological state to create portals of entry for therapy.
And I think humming in a therapeutic session would only be helpful if you do it together, because otherwise, in a sense, it can even be a threatening more, or that somebody feels ashamed or something like that. But when you do it together, it's the encounter is reinforced.
Yeah, I think that if you do it alone, a person doing it who's already under a state of threat is going to feel like they're being evaluated. Did I do it right? And again, so much of our society is based on evaluation, which is really cues of threat, whether it's academics or even medicine. You go in, you get tests, and those tests make you, quote, anxious. But what is anxiety? Anxiety is our psychological label for when our body shifts to a state of threat. So we use, in a sense, words that confuse us. So is there a difference between anxiety and stress? They have, in a sense, we're using labels, and those labels are really simple. I mean, there's a simple process, and that is our autonomic nervous system shifted out of a state of safety that supports homeostasis to now a physiological state that supports defensive reactions. And when it does that, of course, we get all these other comorbidities in terms of medical illnesses, because the autonomic nervous system is no longer doing its job. Well, it's doing its job to try to keep you alive in a world of threat, but not doing its job in managing the internal organs.
That's interesting when you say. That brings me to this idea. From my understanding, for example, in Germany, we have a double bind as a therapist when somebody has to work with the insurance companies. Then he has always to put a diagnosis. But for many people, not for all, but for many people, in my experience, a diagnosis, or the process of establishing a diagnosis, is like an examination or like a test. And in that sense, also has some threatening impulses for the people. What do you think about that?
Well, okay, so I, like you, am not a big fan of diagnosis because it diverts us away from the underlying process. And when you brought that up, I started to think about the Nobel Prize speech by Walter Hess in 1949, which no one learns about. It's the Nobel Prize in Medicine or Physiology. And he got the prize for documenting that the brain regulated our autonomic nervous system. You know, it was like you don't have a nervous system of the body and one of the brain, you have one nervous system. And I would actually recommend that everyone go online and find the Nobel Prize speech, because in the opening paragraph, he starts talking about everything being related to everything else. And I often read the quotation from that first paragraph and say that if I put that in a manuscript or in a grant proposal, I would never get funded, because it basically said, he actually makes a statement that we've known through the ages about how systems will relate to each other. In a sense, new systems are related to older systems related to new. So it's not like we separate the head from the body. They're talking to each other all the time. And so there's an important thematic strategy that was not picked up by medicine or mental health. It was like when you go to an internist and you have problems and they can't find anything on the test, they often will refer that person to a psychiatrist, because they can't diagnose this, it must be in the head. And this misunderstands how the head and the body work, that the physiological symptomatology is really due to the neural regulation of those visceral organs. Yet, virtually no knowledge is conveyed to physicians who are internists about the neural regulation of the organs that they are working with. They're looking at the end organ and seeing that as a site of disease and damage, without an expectation that the neural regulation of that organ is a contributor to either its health or its disease. So if we live in a stressful world, what we're saying is that under states of threat, the neural feedback between our brain, especially our brainstem and our organs, is not supporting homeostatic function. It's not supporting our health. What's the long-term consequence of that? The organ that it was supposed to be regulated gets diseased or dysfunctional.
But that means, in a sense, for me, what you say is, I think it's very important also, especially for therapists, because in a lot of supervisions, I always then get reports from the colleagues of the, Mr. So-and-so is a borderline personality, or is that or that. That, in a sense, separates us. This kind of dignifying kind of description, and what we just need in those cases is this other kind of interaction of encounter. What you are talking about, to put a frame of safety.
Right, and when we move into these diagnoses, and this is where I kind of like have moved into a lot of this medical or biological psychiatry research. Often what we think are separate diagnostic categories have tremendous overlapping symptomatology that is really telling us about those lower brainstem structures, like flat affect, intonation of voice, vagal regulation of the heart. And so these become, in a sense, these underlying foundational disruptions. Then what the diagnoses start to tell us is that as we disrupt those foundational health growth, homeostatic functions, the rest of the brain doesn't have the feedback that it's getting from the body or the lower part of the brain, and it self-organizes. And this self-organization strategy could lead to a variety, if not infinite, manifestation of clinical symptoms. So I got an email this morning about a young lady who was getting diagnosed with schizophrenia, who had, in a sense, antecedent trauma history, and her mother really wanted to know what I thought. And the issue from what I thought was that being in a chronic state of threat, which she had experienced for her early part of her life, literally gave permission to those higher levels of brain structures to reorganize, because the feedback loops were not metaphorically as grounded to the body, and we keep forgetting that our visceral organs have a pathway up to the brainstem, then it goes up through insular cortex. And literally, we can actually draw a picture. It looks like we're plugging our cortex into the body. And we have to think about this, even the metaphor of being a grounded individual is really saying that there's a connection, or co-regulation is even a more rich term, between higher brain structures and lower brain structures in our body.
Just some more questions about this therapeutic field, and then we can go maybe also to other things. For example, that is more addressed now to the hypnotherapists in our field also. A lot of hypnotherapists, I'm also a trainer in hypnotherapy in Germany, they always have this understanding when somebody comes, is under stress or whatsoever, the first and best thing you can do is to offer him relaxation. But from the Polyvagal-Theorie, I think we would have to differentiate that, because then they are surprised and sometimes very irritated when they offer relaxation offers, and somebody becomes even more tense than ever.
Yeah.
And you have a good explanation for that.
Well, you're structuring an expectation and they can't meet it. I would have a different strategy, and I use this in my lab. I created what we call a coffee culture. Anyone who came into my lab, we offer them a cup of coffee. You now have an engagement, and they say, well, I don't drink coffee. And then you say, would you like a cup of tea? They said, no. Then you say, how about a glass of water? So you're creating a dialogue of reciprocity and co-regulation, and the behaviors are inviting. And again, within, I would say, most clinical situations, it's in and out, especially in medicine. You have to, well, in the US, you have to process patients within 8 to 15 minutes. And that doesn't make any sense, because it takes time to feel safe with another. I am still amazed that when you go in to see a physician, and you let's say you walk up a couple of flights of steps and you're in the office, immediately they're taking your blood pressure. And without assuming that blood pressure is a static measurement that's unrelated to the context and unrelated to mobilization, rather than saying, sit down for a while, this is very common. And then they start labeling it white coat hypertension, so they're in a sense of saying, rather they should have said, we've messed up, we've been disrespectful to your body. And we want you to know that we're very welcoming here, and we understand that your body's going to react to uncertainty, like every nervous system will. And we want to minimize that uncertainty.
So not so, or you could say many high blood pressure diagnosis may be an artificial diagnosis in a sense.
Oh, we all have been on that journey. And so, I started to get an elevated level. And of course, they want you not to leave the office, right? Without, some medication. I said, don't worry, I'm going to go on my own regime. And I went on, basically, I did baroreceptor exercising. I have a tilt table. So I go up and down for a few minutes every morning. And in a sense, to exercise the neural system that regulates our blood pressure. And it regulated, stabilized. But the pandemic wasn't good, because we're not getting the social nourishment that we're used to. But the issue is, when we understand that blood pressure is not static, that there is a neural foundation for blood pressure, we can optimize that system. Now, I don't want to minimize the fact that you can have diseases of hypertension and they need to be monitored, and not everything, our intentions to exercise these systems may or may not work, depending upon the status of your system. But for me, my blood pressure is normal, which is quite good. I would say good for, given the fact that I'm advancing in age. And so when I go to see a physician, the first question is, what drugs are you taking? And I say none. I take supplements, but I say no drugs. And they're almost in shock. And my point is not that drugs are uniformly bad, is that when you take them, you are often paying a price. So when you take blood pressure medicine, you have many of the blood pressure medicines lower blood pressure, but they increase blood pressure variability. And in doing that, they actually increase the risk for stroke, which is kind of paradoxical. So you can lower the blood pressure. And now, why are you lowering it? To reduce the risk of stroke. And now what's happening, because the system has lost its ability to constrict and raise pressure, it now has to recruit different mechanisms to stimulate or to compensate. And that is blood pressure variability.
To come back to this, what I asked you there, my impression is that, for example, when somebody offers relaxation, that is in many situations too early, because relaxation needs the experience of safety at first. And safety, from my understanding, especially in a therapeutic context, is more experienced when somebody gets the message, hey, you can be here, I'm with you, and you don't have to change anything. In the moment, you don't have to change anything, even not your stress, just we are here, and then we look, and then afterwards you can.
Okay, so you made a very important, strong point. If we insert or change the word relaxation to say vulnerability, are we asking the client to be vulnerable? And that's what you're doing, and you interpret it correctly, and you can't ask someone to be vulnerable. I have this concept of a continuum of accessibility to vulnerability. And where if you were to engage me and say, relax, I would interpret it as you want to be accessible, want me to be accessible to you. But if you carry a trauma history, and many people do, and if that gets translated into a physiology that is in chronic states of threat or anxiety, you'd call it, or stress, then being told to relax or even being asked to relax is going to trigger a vulnerability. It's going to say, if I relax, I'm going to become vulnerable. And now, as opposed to engaging the client to make the client more accessible, you have amplified and emphasized the client's own view of herself or himself as being vulnerable, which is probably the way they feel.
Yeah, exactly. Yeah. One additional question, and then I would like to ask you something about SSP also. So that especially in the field of addiction therapy, which is a field where I'm working very much also in it, there's a lot of belief systems in the part of the therapists. And so, for example, if somebody does not change and they try to help him to change, but he doesn't change, then it's like a kind of a so-called truth that many people say, well, I think he has not enough pressure of suffering. He needs more pressure of suffering, otherwise he won't change. For me, that's terrible, and it's just dangerous. Could you say something to that also?
Well, I think you've said it. That's for both of us. But it's a misunderstanding. It's focusing on addiction as intentionality. And it's saying from a behavioral perspective, if I increase the motivation, the rewards, or the punishment, then the addiction will disappear. That hasn't worked. Exactly. I mean, we have to really say, what is addiction? So this is actually an area during the past few years I've been pulled into learning more about it and seeing it through a polyvagal lens. Basically, on the simplest level, addictions are valiant attempts to regulate your physiological state, to try to be in the state that you are comfortable with, unless meaning that you're not vulnerable. So if you think about the history of those who have addictions, so if you look in terms of their clinical history, there's a large overlap with adversity or trauma histories. And then if you go and ask the polyvagal question about severe trauma, and that is, if your body shut down, if you immobilize with fear, it's like dying. And there's only one way to stay out of that, and that's to keep mobilized. I say one way available to these people, because they're not safe to recruit the social engagement system. So they have to stay out of immobilization. And so you see this frenetic behavior. And if things start calming down, then they're taking certain types of drugs that keep them mobilized. So I see it as strategies to regulate their physiological state. It's certainly not the sole explanation. And I've been in dialogue with addiction specialists, and they talk about other dimensions of the addictive process, of people literally identifying and becoming, in terms of what they're addicted to, that identity, and what we would say earlier in terms of diagnosis, that this becomes a point where they now feel they have a group. So there's a connection model. So if they're exercise addicts, sex addicts, alcohol, they start clustering into people who share their experience. So it becomes something more. It's an identity. I'm still learning on this, but the simplest part that I can understand is that these are strategies to regulate physiological state. And they're strategies to regulate physiological state when social engagement and co-regulation are extraordinarily limited.
Exactly. And then can you say, in a sense, it's an attempted solution which has a high price, but it's a solution out of a state of defense. And if somebody can be supported to reactivate the social engagement system so that he can get into a state of safe choice, that would be the way to go.
I hope so. So I start to think along those lines, and I actually visited some addiction centers and was really kind of noticed that a lot of addiction centers have group psychotherapy, or groups they run. But the groups are basically, I would say, cheerleading rallies. And I thought they could be reframed as experiences, shared experience of visceral state. So I wanted them to use techniques like the Safe and Sound Protocol, which is this acoustic stimulation that I developed that triggers physiological shifts. I want them to do heart rate monitoring. I want them to do some biofeedback exercises. And all the group would be doing would be discussing individual experiences. So people are sharing what it is like to feel their body. Because I think part of the journey of an addict is not to go into the body, to feel the body. And that if the groups were about touching, for instance, touching physiological state, then you're on the strategy of, you have a strategy of moving them out of that.
That brings us to this.
Sorry, Unda? Just one thing, just one question, because we have two very interesting questions from the audience. Is that okay? You wanted to give some theme again, and then we can have two questions. Is that okay?
I thought we come to this question later. Or is it,
no, I think you can do it now. And then I just wanted to say that we have two questions. I think they're very interesting on dissociation.
I just wanted to pick up the SSP now, just in a moment.
Of course. Yes,
because,
thank you.
Stephen, could you say some words about the SSP, the Safe and Sound Protocol? Because once I've seen once a video where you showed a video with a young man with an autism, and at the beginning when you encountered him, it was he didn't make any kind of direct contact or things like that. And after listening for some weeks to the Safe and Sound Protocol, it was very touching and impressing to me how this young human being changed so much that nobody would have expected that before. And that thing has a lot of impact also for other therapeutic and other things.
So basically what you saw was, after the total intervention was 5 hours. So it was 1 hour on 5 sequential days. And it was an adult autistic who had been autistic since childhood. He was 40. And when he started, he was no eye contact, and we ended. He was engaging me. He was doing role reversal. He was smiling. He was asking other people about how they felt. And we've seen this a lot in terms of both kids and adults. And my view is that there are a lot of people who carry certain diagnoses, and those diagnoses are based on the body being locked in a physiological state of threat. And that, for many, is reversible. And when you reverse that, the diagnosis disappears. It's not curing autism. It's curing it's basically taking some individuals out of the diagnostic category. And we have to really understand that if we can take people out of the diagnostic category who are based on a physiological state of threat, we can start understanding what autism is, as opposed to mixing it up with all other types of atypical behaviors, from no language. I mean, there are a lot of things going on there. So basically, the model of the Safe and Sound protocol was really based upon the intonation of maternal vocalizations. What does a mother do to calm her baby? Well, she uses a prosodic voice, which is more intonation, more melodic, more calmer. We just published a study, my group, on maternal vocalizations following the still face procedure, which was developed by my good friend Ed Tronick, in which the mother plays with the baby and then freezes her face. And they're 2-minute segments: play, freeze, and then re-engage. And the baby's heart rate was being monitored, and the mother's voice on re-engagement was being monitored. If the mother's voice had more intonation, more prosody, the baby's heart rate calmed down. If it didn't, the baby's heart rate didn't calm down. And we were measuring the baby's behavior, and the baby's behavior paralleled that as well. So it became less disruptive, more engaging. So we know, and of course parents know this, but it's not, the fact is all the mothers were trying to engage their kids, but some mothers were more effective, and those were the mothers with more intonation in their voice. And in a sense, this is a powerful understanding. So I developed this strategy of presenting vocal music that was computer altered, meaning that there was an algorithm that amplified the intonation changes. And I viewed it as a stealth intervention, that people wouldn't know they're having an intervention. And I viewed it as, in a sense, distilled essence of trust. What is it in vocalizations that our body can't say no to? And they'd start to use it with kids who had basically auditory hypersensitivities, and that became a target because the middle ear muscles are part of that social engagement system, and we retune when we're in states of threat to detect predator sounds at the expense we can't process human speech. And many of us have all experienced that if someone was yelling at us, we can't understand a word that's going on. Or, as we get older, we have the same problem. But the issue is that we understand that there's a link between our autonomic state and whether we can process auditory information. And this basically said we can change the directionality. We can create an acoustic vagal nerve stimulator to calm people down. And that's what the Safe and Sound protocol is all about. Now, what was interesting, and this is very relevant to what most of us do, and that is what happens when you use this with people who have a clinical history of severe trauma. Now, when I started, I thought, oh, they'll become open and engaged. Well, what happened is that the initial, after listening for even, let's say, a minute, their bodies start to relax. But what is that relaxation now, Gunther, for a person who carries trauma? That's vulnerability. So the body goes like this, and the person says, can't take, pulls the headset out and goes out of the room. Now, we had the same example in Poland with the Ukrainian refugees, because they're Polish providers of the Safe and Sound protocol. And they, with great expectation, wanted to deal with a mother and then with her child. And they put the headset on the mother. It's just computer altered sounds. And the mother lasted 46 seconds. And headset went off and she had to get up and move. And so and again, the movement becomes part of it. And I now think that if SSP is intertwined with a movement protocol, that we may be able to move it into that type of population. So the point I really want to make, so the bottom line of all this is, even though it had counter indications with people with trauma histories, the insightful trauma therapists said, I can work with this. And what they did was titrate. They used very few seconds so that person became familiar with it and then started to experience the physiological states. And now the signal power of those physiological states of accessibility were no longer signals of vulnerability. And they basically were able to use the safe and sound protocol to accelerate their treatment models. And there are groups, actually a relatively large group of 200 or 300 somatic experiencing practitioners are using it. And now several EMDR people are using it to facilitate their own treatment strategies.
So I see Matthias Ola already having this question.
Sorry.
So I would at least relate to one thing, but also maybe namely to apply that the whole polyvagal theory perspective also to the development and constructing or cooperation in organizations, which is also a very important thing, especially. But maybe we can.
Well, I'll just make a final comment on the Polyvagal Institute website, polyvagalinstitute.org. There is information on organizations that can be certified as polyvagal informed, which is really all about how organizations have to learn about social interaction, respect for other people's physiological states in an organizational model.
Yeah, that was for me, by the way, when I developed the organizational concepts of our clinic. That was one of the baselines was also your polyvagal theory. And also what you once said, I liked it very much. Do we want to work in a reptile organization or in a mammal organization? Because the mammal organization puts on, focuses on cooperation, on supporting each other, on also talking in I receive and not you are. And so, and also, for example, if somebody makes a so-called mistake, that there is a presupposition of he did it on his best intention, and not because something else, as a trust presupposition, supposition, and not a accusing supposition. And so, and that is for everybody there a much more healthy kind of environment. And only then the therapists, for example, can be in a mood themselves that they can, in a sense, be present as a safe environment for other people.
Yeah, the final point on that, I totally agree, is that when you create the culture, your staff co-regulate with each other. Exactly. And you don't have burnout, and you have job satisfaction, and you learn from each other.
So that is learning from each other. I learned from you again and again. So it's the same.
It's a journey. You're taking me on a journey to discover. Thank you. So I think we have a couple of questions burning on me.
Yeah, I mean, it could happen that at 6 p.m. Zoom will freeze us out. So I will just take one question, and all the other questions that you have come to the Congress at the 22nd of June, and Gunther will be there, and Steve will be there, Waldemar Hartmann will be there, and many other people from Belgium, from Poland, and so on. I take a question that Waldemar told me. I'd make it just short. Stephen Porges, would you regard dissociation as occurring as part of the parasympathetic dorsal vagal state, or could dissociation also occur as part of the sympathetic state?
The answer is yes. The longer answer is, if we think of dissociation as a evolutionary or an adaptive, nuanced way of dealing to life threat, it's really quite remarkable. Let's paint this narrative. Let's kind of describe this, that the first time a person is in a life threat situation, they totally shut down, they may defecate, pass out, and that is actually potentially dangerous and lethal to the nervous system. Not enough oxygenated blood, and of course, falls can really injure you. But what the nervous system learns is to, in a sense, get the body into a safer place. So it can, in a sense, immobilize now without shutting down. To do that, it needs to get enough oxygenated blood to the brain. How do you do that? You have enough sympathetic tone that you don't pass out and you don't move. So the freeze, to me, is this sequential adaptive inhibition that is utilizing many of the attributes of that dorsal shutdown response and modifying it with sufficient sympathetic tone not to pass out, not to fall over. So I think it is a remarkable one. And I, like many others, people got confused in the beginning in our labeling and started to talk about freeze as if it were part of a dorsal vagal response. I think dorsal vagal contributes to it, but I think it's a hybrid between dorsal vagal and sympathetic.
And I would like to add something, because when somebody is talking about dissociation as a therapist, I think that is not enough, because when does a therapist say that? Usually when he wants to get into contact again, into contact with the people who in this moment of what they call dissociation moved out of this kind of encounter into another world. So it's much more important, from my understanding, to ask with which kind of experience is he in the moment associated, or maybe with the immobilization state. Therefore, it's to differentiate the dissociation. It could be also that he is more associated with the fight, flight thing, and that you have to address in a total different way compared to when he's in an immobilized state.
Yeah, well, again, if we think about parts or personality parts, and think about dissociative personalities, not just the act of dissociating, but when it fragments into different type personalities, what are the initial three parts that would break into? A social part, an aggressive fight flight, and an immobilized or victim part. And so you literally see in breaking this apart that polyvagal-theory gets manifested in dissociative identities.
Mm-hmm.
Well, you both, thank you so much. It was wonderful, and the hour was flying away.
Yeah.
We
have just some minutes. 1 minute, I would say something to the situation in Ukraine and before that, and the pandemic. I heard something by Steve, which was for me very orientation giving, when he talked about the COVID, Stephen, you talked about the COVID situation as a paradoxical situation. That was for me very understandable, because usually human beings develop safety when they have encounter, when they can come together. And in this pandemic situation, exactly that usually makes even the threatening more, because then we can infect each other or something like that. And for a lot of people, also especially for young people and children, that was, I think, all over the world, a terrible paradoxical situation. Would you have there an idea how to solve that?
Well, I'm still in the act of recovering, because social nourishment is what we all need. And I'm actually going to be traveling at the end of this month for the first time in over 2 years. And I'm talking again in June. I really crave interacting and being, let's say, in front of people and talking to people. And I also realized that the 2+ years for me retuned my autonomic nervous system. When I still see people, I still pull back. So the paradox is that, of course, there's a real threat out there, but how have we really resolved threat before through co-regulation? Now co-regulation became a threat. And I think we need literally to have rehabilitation sessions. So for me, it's going to be attending meetings. I'm going to see how my nervous system deals with it.
And I hope very much still, I invited you again to our Reden reicht nicht Congress, that maybe at least in a Zoom way, but maybe even presence you are here, that we can co-regulate also at the Congress.
I would love to. You need to re-engage and see if
I do.
This was a good idea, Gunther, to co-regulate when we at the Congresses. Thank you very, very much, you two. And I'm happy to know you and to know all the people that were here. Thank you to all people that were here. Let's see again in June and in October. Thank you, Gunther. Thank you, Stephen. And thank you to
Thank you, Stephen, very much for our encounter and for just the way you, also as a human being, as I experienced you. I think you don't, as you, in your language, some people say, he walks the talk.
Yes.
Thank you very much.
Sure.
Okay.
Thank you
Have a
so
nice
much.
evening, all of you. And it could happen that Zoom throws us out. And I think it's better to say goodbye live and not let the machine do that for us.
Okay. Thank you.
Thank you so much. See you again soon. Thanks.
Okay. Bye-bye.